right, it's right at 2 o'clock, so I think we will go ahead and get started. Some of the things I'm going to talk about today are just common sense kind of things, not common sense, but just regular speaking points. I'm not going to show you a bunch of studies and a lot of graphs and charts and data and things like that. We're just going to talk about what happens at UAB Hospital and kind of where we've been and where we're going. The reason this topic is called Managing Rough Seas and Reaching the Harbor Safely is because I actually did a talk on inpatient glycemic management in Baltimore, Maryland, a couple of years ago. And so I just took this PowerPoint and kind of adjusted it to fit our needs for today. This is me. I look much better in that picture than I do in person. But that's me when I look fabulous. I'm not going to go through the objectives. You can look at those when you look at the slides. So there are a lot of challenges, as you know, to inpatient glycemic management because of all the shifting variables that happen in the hospital. Patients are transferred from one unit to the other, or from hospital to Spain rehab, or from ICU to the floor, from the ER to the floor. And then insulin is our safest therapy to use in the hospital, believe it or not. For some people it's very difficult to use, especially if you're not used to using insulin therapy. But it is a lot safer than using the oral meds. And then, you know, the cornerstone for diabetes care and initially for a lot of patients is, besides diet, is metformin. And, you know, we place metformin on hold and we place most of the other meds on hold. And we'll talk about that more in a little bit. And then hospitals are not designed for highly coordinated care. You know, if a nurse has 5 patients and 2 of them have diabetes, then she has to take a special, care to know when the patients ordered their meal, when the meal came, when they ate the meal, when to give insulin. And that's in the middle of doing all the other things that happen in the hospital. And so it's very difficult. It was a lot easier back in the day when you had the meal cart to come up and park on the floor, and you could check everybody's blood sugar that needed to be checked, and you handed out the meals and then you picked them up. And so, but patients don't like that. They like to be able to order their own meal and eat when they're ready to eat. And then I mentioned transitions of care, and that is a time when there are increased chances of error. And a couple things I want to mention here, and I'm not sure if you guys know about it, but when you're in the emergency department and you order a dose of insulin, they don't have the ability to store the patient's insulin pen in the, what's the machine called that they use for medicine dispensing? What's it called? Pyxis. In the Pyxis system. So anytime you order a dose of insulin, once they use that pen, they discard it. They send it back to the pharmacy. And so you can imagine that patients that are housed in the emergency department for several days may have their pens discarded after they're used, and that's an issue. And we've talked to them about it, but they don't have the room in the Pyxis to have patient specific medications. Also, if you have a patient that transfers from the intensive care unit, they don't transition those medications with the patient. They're not allowed to travel with the patient. Now, sometimes they do, but they're not supposed to. And so when your patient leaves the intensive care unit, and let's just say they've been admitted for DKA and they move to the floor, those medicines have to go back to the pharmacy from MICU, and then the medicines that are ordered have to come up to the floor instead of them just being transferred over with the patient. And sometimes there's a lag time. So those are some specific things that I don't know if you are aware of. One of the other things that you need to be aware of is that patients that have hypoglycemia are not necessarily, the labs are not necessarily reported out as an alert value from the lab. So their alert threshold, I believe, is at 54. And as you know, below 70 is hypoglycemia. And so there are some instances where the patient's blood sugar may be in the 60s, and if nobody looks at the ordered labs, then by morning they could be much lower. So those are just some snags in the system that you should be aware of that might help you to navigate your patient's care. And we'll talk about some more pearls at the end. So sliding scale is a rational attempt at flexible therapy. But as you know, if you wait for the blood sugar to go up and then bring it down, you're really, the patient's on a roller coaster ride. And so, unfortunately, it does not work very well. And so in 2011, a team was gathered together to come up with a proactive way to manage diabetes, and the basal bolus program was invented. And the hospitalists were early adopters of this program and were thrilled to have a program like this. And we actually piloted it on a hospitalist unit on P9. And then it rolled out 1 or 2 units at a time over a couple of years back in those days. And it has been in place ever since then. And we've been able to significantly impact severe hyper and hypoglycemia. You guys are aware of our power plans. One thing you may not be aware of is how we are split up. So in the early years, we had just a glycemic management nurse practitioner team. But as our fellow service grew and we went from 4 to 8 fellows in endocrinology, we developed a fellow service as well as an NP service. And so patients that are in vascular surgery, on the oncology service, on CV surgery, and on women's services, as well as the ICU patients and the ED patients, are all managed by the fellows. Now, just because HSP2 happens to be in the WIC, they're grouped in because it was the only other unit over there that we were going over there, and they were following all the other patients in all the units in the WIC, so they picked up HSP2. So any non-critical care unit other than the services that I've said are covered by the NP service. And we get all of the patients that are on tube feedings, that have insulin pumps, those who are difficult to manage like steroid-induced type 1s, anybody that you send a consult to us for, and then we have system-generated consults. In the beginning, we did a glucose threshold of 300. Over the years, we've lowered that. So if your blood sugar goes above 200, we get an automated consult to come and see your patient. And as you guys know, we enter the orders whenever we see a patient, and we usually do not reach out to you and say, hey, we're seeing a patient, we're entering orders. So you guys are probably already aware of that situation. If you have 1 glucose reading below 54 or 2 below 70 in a 24-hour period, we get a consult. And then we have some that are built into the order sets or some other way in the system. So for patients on an insulin pump, in the nursing assessment, it asks if the patient is wearing a device. And if they click that they're wearing an insulin pump, we get a consult. The order set for an insulin pump has a consult for the glycemic team. People that are on TPN, so a lot of those have people that are on dialysis, we get those. We get all of the CF patients. We cover Spain and the CPM hospital. And then the NP team used to go to Highlands, but we also had an attending service that went over to do endocrine consults. And so we had 2 groups of people traveling over every day. And so they grouped that into one service, and it's managed by an attending physician now at Highlands. And they have about 4 people that rotate over there. And I know one is Abdul Hadi, and most recently Ann Weaver and Moladina, sometimes O'Balier will go over there. And we are just about to start a service at UAB Medical West. So I'm in the process of interviewing and hiring 2 APPs that will cover UAB Midwest. Okay, strategies for caring for hospitalized patients. First of all, we'll talk about insulin pumps in the hospital setting. And you guys do a really good job most of the time of leaving a patient on their insulin pump. At one time, y'all had a hospitalist who used to take everybody off of them. I don't not want to call their name. But anyway, our stance is that all patients on an insulin pump, if they're awake and alert, will do better in the hospital if they are maintained on their pump. And so we usually encourage anybody who's on a pump, especially if they want to manage their own glycemic control, to be left on their insulin pump. And we haven't had a lot of problem with patients being hypoglycemic. There's a lot of technology that goes along with insulin pumps now. There's Control IQ is a program that will go up and down on the insulin rates that the patient is receiving and help to prevent hypoglycemia and hyperglycemia. And so they do have to have their own supplies because there are a lot of different pumps and there's no way we could stock all the supplies. And then the patients are given enough supplies for a 30-day supply, and so they have their own supplies and they have to bring them in. If they don't have their supplies, then they have to come off the pump and we put them on basal bolus insulin. So I put this in there because I talked about it at the conference I was at, and you guys, I don't know how much you want to know about the insulin pump, but some of the main things to know is what type of insulin a patient is on. For the most part, they're going to be on a rapid insulin, one like Humalog or Novolog or something like that. There are a few patients that are on a pump that have U500 insulin, and all U500 insulin is escalated to the fellows team. And that's because we had a sentinel event regarding a patient with U500 insulin at one point. So they have to be managed by an endocrinology fellow and attending. It was nothing that the NPs did. It had to do with, a dosing error, and the patient got way too much insulin. So. But on an insulin pump, we always see every patient and follow them when they're on a pump, and we want to know their basal rate. And the pump works by, glargine is our basal insulin. It's a long-acting insulin. But to get the basal insulin for somebody on a pump, they just have rapid insulin that infuses all the time. And then the insulin to carb ratio is calculated for them to put in their meal that they eat and get a bolus for that. And then the sensitivity or correction factor is used to do the correction. Now, in the hospital we have very high, moderate, low, very low scales. And they're based on an insulin sensitivity factor or correction factor. And I have that, and I'll send it to one of you so that you can see. And that way, if you see a pump and you see on there, I don't know how often you guys go into the pump and look at their settings, but if you see their correction factor, you can correlate it with the sliding scale that would be, or a correction scale that would be appropriate if you need it. And then the active insulin time is the time that the insulin is on board. So as you know, rapid acting insulin, the onset of action is just a few minutes, like 5 or 10 minutes, and it's actually cleared within an hour, but it can actually stay in your system for up to 4 hours. So if you dose over and over again, you know how people like to get a blood sugar and it's 600 and they give a bolus and then they want to check it in an hour and you're tempted to give another bolus, and sometimes people will do that 2 or 3 times. And so over a period of time, you get insulin stacking and then you get hypoglycemia from that. And so the active insulin time is usually set at 4 hours in a pump so that you don't get that insulin stacking, and they can try to bolus as often as they want to, and it will not give them too much insulin. So that's a safety factor that's in the pump. So I had a patient in the hospital and she used a pump at home. She didn't have her pump, and she could not tell me her pump settings. She followed with a physician in Jasper. I spoke to the office, and it said, the medicine list said that she took up to 40 units of basal insulin through her pump, but I couldn't actually get the pump settings from the physician's office. Oh, actually I must have. No, here it is. Her pump arrives to the hospital, and she does get about 40 units. So from 12 midnight, her pump pumps in 1.5 units, 5 units an hour. And then at 11 a.m. it gives her slightly more, and at 8 p.m. it gives her a little bit less, for a total of 40 units a day. And then her bolus settings are set there, and her active time was 3 hours instead of 4. You also have to know what your target is for the insulin pump. So if you look at this, I'll orient you. So it goes this way. It goes from right to left. So if you'll notice on her aspart, she was only getting 4 units. And then at bedtime, she didn't need any correction. And at 8 o'clock the next morning, she didn't need any. Her blood sugar started out pretty high, but trended down into the target range. So in the hospital, the target range is 80 to 180. But if you're in a critical care setting, it's 140 to 180. You don't want them to get below 140 because they're critically ill. So as you can see, she's not receiving anywhere near 40 units in a day's time, okay? So when I talked to her more, she had been in the hospital and had been sick in and out, and had lost about 20 pounds. And so she also did not eat in the hospital like she ate at home. You know, sometimes people drink lots of sweet tea and things like that. So what I did is I took the amount of insulin that she required, 4 and 4 and 9 and 9 and 1. So she was getting about 18 units of basal insulin. And so I reconfigured her pump to give her 20 units of basal insulin because she was doing pretty good on about 18 units. And so sometimes we have to adjust the insulin settings. If any of you guys are interested further in the insulin to carb ratio and the correction factor and how we get those and more about pumps, let me know, and I can just do an in-service on pumps and how we come to those settings and things like that. All right, so your basal should be about half your total daily dose of insulin. And then in this instance, she was getting mostly basal, but she was in the target range. And then she had a lower basal rate at night when I looked at her old pump settings. So all I did was just kind of finagled around until I got it, made it a little bit lower at night. And then these slides tell how I got the insulin pump settings. I'm not going to go through those in depth because I have a lot of other things that I want to talk about. But again, I'll come back if you want me to, and then you have the slides. And we put her pump on, and you can see there was a little bit of a blip, in the transition, which is not unusual. And then her blood sugars were pretty good. Okay, so if you do the reverse and you have a patient that comes in with basal bolus and they need basal bolus and they're on a pump, you take the basal rate should be your long-acting insulin dose. And sometimes we will give 70% of that, like we do when we configure the home, insulin injections. And then her insulin to carb ratio is 1:8, and just briefly, 1 serving of carbs is about 15 grams of carbohydrates. And so we know that she was on a 3-carb diet, so she got about 45 grams. So you take the grams of carbs that she's getting in her diet, assume she's eating all of them, and you divide it by the insulin to carb ratio, and that gives you your nutritional insulin dose. Does that make sense? Okay. And then on the correction factor, I have, and this tells here, the different scales are low, moderate, high, very high. And so her correction factor was 1 to 30, and so she was between the low and the moderate. So I just, chose a moderate scale for her. So she got glargine, 18 units nightly. If patients have type 1 diabetes, sometimes we'll split the dose of glargine because glargine is, everybody calls it a 24-hour-a-day insulin, but it actually starts to wear off at about 22 hours. And then the onset of action is about 3 hours. So you have about a 5-hour window where you don't have any insulin on board. And for people with type 2 diabetes or that have some kidney disease, that doesn't really matter. But if you have a true type 1 patient, sometimes they'll start to go up and could even start to go into DKA 5 hours without insulin. So sometimes we'll split the dose. And some people are not as sensitive about, going into DKA as others. So a lot of times I'll ask them if they ever taken glargine before, and if they did okay with it, just 1 time a day. And if they did, I'll just do 1 time. If they take something like Tresiba, where it's ultra long acting, or if they say glargine doesn't work for me, I get high, then I'll usually split the dose. All right, transitioning from an insulin drip to sub-Q insulin. First of all, you want to know why they're on an insulin drip. Are they in DKA, or is it just part of a post-op protocol? Or did they have some hyperglycemia, but they never were actually in DKA? Do they have uncontrolled diabetes? Are they getting steroids? Are they having other complications like an infection, things like that? And if your answer is, does the insulin need to be adjusted, and it's no, you can convert them back to their home regimen using the principles of basal bolus. If they need adjustment in their insulin, and you'd look at the drip to see how much insulin, you don't want to use the insulin amount that it took to bring the blood sugar down. They need to be stable on the insulin for several hours, and you look at 3 or 4 hours, and then you would, multiply that and make it a 24-hour if they were getting that amount every hour, and then you can divide it out. And we usually give 80% of what they were getting with the drip. So 60-year-old with diabetes, hypertension, asthma, depression, had a craniectomy. She was on an insulin drip for glucose management while in the ICU and needed to convert. She was on an insulin pump. And one of the biggest things about converting a patient from IV to sub-Q is that because of the onset of action of your glargine is 3 hours, you need to give the basal insulin 2 hours before you turn the drip off. And then you have about an hour of overlap, but that won't hurt anything. Whereas if you have that 3 hours and you've turned the drip off, regular insulin, when you give it IV, only lasts 5 minutes. It doesn't last like sub-Q regular insulin and stay in your system 4 hours. So as soon as you turn it off, within 5 minutes, it wears off. So that's why you need to overlap. And you can see, again, we're going this way. And her blood sugars were not fabulous, but they gave, it was still 230. So you could argue that it wasn't time to change her over. And the other thing is she was not on insulin because of DKA. Remember that. If you're on insulin for DKA, you don't look at the blood sugar when you get ready to convert. you have to make sure that the acidosis is resolved. And that's why some patients in DKA need IV fluids with dextrose in it until their gap closes, because the glucose is no longer the problem. It may be the triggering factor, but you've got to get the acidosis resolved. But in this case, she could convert over being a little high because she wasn't in DKA. And they gave the insulin, and by the time they turned the drip off, you know, she was pretty good and she did okay. All right. Now, she could have gone back on her insulin pump, and in that case, you would have them to put the insulin pump on and then turn the drip off in about an hour. All right, you guys know about DKA, and that's kind of blurry, I'm sorry about that. But you have acidosis, ketosis, and hyperglycemia. Causes are non-compliance for whatever reason, a lot of times unaffordable insulin. It is a CMS never event for a patient to go into DKA while they're in the hospital. And I'm sure you guys have all seen that happen, and it's a never event. So, other factors that cause it are infection, alcohol, stroke, MI, pancreatitis, trauma, and some medications. All right, there is a DKA while waiting to transfer to the floor power plan. Transfer to the ICU power plan. Are you guys all familiar with that? Okay. So as a provider, you have to evaluate the patient every 2 hours while they're on that power plan before they move. Did y'all know that? You're supposed to, it's in the orders. All right. You know a person has the DKA is resolved when the blood glucose is less than 200, when the bicarb is less than 18, and the pH is greater than 7.3. All right. That's DKA and conversion from IV to sub-Q insulin. All right, let's talk about steroid-induced hyperglycemia. We use prednisone or methylprednisolone, dexamethasone or hydrocortisone, and if a person is taking prednisone in the morning, their blood sugar is going to rise throughout the day and peak around supper time or bedtime. So if you look at the morning blood sugar and it's in the normal range, then that's a trick. Don't fall for it. They didn't just get better. Also, don't use a correction scale at bedtime because they're going to automatically come down during the night. And if you give them correction at bedtime and they're automatically going to, the effect wears off, then you may cause them to have hypoglycemia. Dexamethasone stays in your system for about 24 to 48 hours after the last dose of dexamethasone. You will often see our team use BID NPH while the patient is on dexamethasone. During COVID, we had tons and tons of people on dexamethasone. And then hydrocortisone is used for stress dose steroids. And a lot of times it's 50 milligrams every 8 hours as for stress dose, and you may see a little hyperglycemia. Now, if somebody has adrenal insufficiency and they're on hydrocortisone 20 in the morning and 10 in the evening, you should not see any changes in the patient's blood sugar based on receiving those steroids because it is a physiologic dose. It's the same as what your body would be producing on its own. Y'all ready to go to the next one? Am I going too fast and jumping around too much? Okay, tube feedings. There are two kinds of tube feedings at UAB, and they are brick feedings and continuous feedings. People on a continuous feeding have BID glargine and every 6-hour correction unless they're in an intermediate or ICU type setting, or sometimes in SCU, they may have every 4 hours. Brick feedings, we do like basal bolus. We give them a basal dose of insulin, and then we order boluses with each tube feeding and correction scale with each tube feeding. So the biggest thing is that you can consult our team, and we're happy to help with anybody with diabetes on a tube feeding diet. Okay, pearls. And then we may finish very early. Is that going to be okay? All right. So here are some glycemic management pearls that I've learned through the years. First of all, the way you know which power plan to order is based on their risk factor, and it says hyperglycemia, but it's hypoglycemia. Sorry, that's a typo there. It should say hypoglycemia. And risk factors include age and whether they, their weight and whether or not they look frail. You won't give some little frail meemaw the same dose of insulin that you'll give a young, muscular guy, no matter if they're supposed to receive whatever, unless they're on insulin at home. If they're on insulin at home, you use the convert from home basal bolus power plan. But if you're doing a weight-based power plan, you're looking at the risk factors to see, and then the other one is changes in their renal function. So if you have somebody on 2 meds, if they're on metformin and glipizide or metformin and pioglitazone, if they're on 2 drugs at home, they need at least a moderate power plan, unless they just had ESRD in the last 5 minutes. In which case you would go with low or very low. So make sure that and try not to just start a sliding scale, even though you're ordering it through a power plan. And I have seen sometimes where that was, warranted. Like they weren't eating well, they're very sick, their, blood sugars are in the 90s, and maybe you want to do that for one day. But for the most part, if they have any hyperglycemia and they're on 2 medicines at home, go ahead and order the full basal bolus power plan. And then pay attention to what time it is when you're ordering the plan. So if they come in and the blood sugar's 300 and it's 10 o'clock at night, well, they just missed the basal dose. So you need to order a now dose. We don't want them to wait till tomorrow night to get the first basal insulin dose. If it's in the morning and they're pretty high, go ahead and order the glargine for daily instead of nightly. What sometimes we'll do a catch-up. So if I'm going to order, let's say I'm going to go up on a patient's insulin from 10 to 15 nightly, and it's the morning, I'll give them 5 units now, and then they'll still get the 15 tonight because I'm catching them up from the night before. So if you're adjusting insulin, you can give them a catch-up dose, and we'll do that up to lunchtime. After lunchtime, we won't give additional glargine because that's too close together and they could have hypoglycemia. It's not on here, but there's 2 ways that we adjust insulin. And you'll notice sometimes I'll double or triple the insulin, and I'm one of the most aggressive insulin users. My other team members, some of them are real, a little more skittish than I am. But if you use the total daily dose of insulin plus 10% is a lot of times what we use and where we're getting those numbers from. So we have a chart that comes up in our note, and it tells the blood sugars and the meals and the insulin dosing. And I look on there for patterns, like did they check the blood sugar before the meal? Did they give the insulin within a reasonable time after the meal? Should be given within an hour. And the pre-blood sugar should be taken within an hour of them eating. In the morning, we'll say 2 hours is okay. So they can check it at 6 and the patient can eat at 8. But if they check it at 6 and the patient eats at 9, you really need another blood sugar because the blood sugars are changing so much. So we look for patterns to make sure things were given appropriately And sometimes the nurse will chart that they ate 50 or 75%, but they don't give the meal insulin, and then they're high in the evening. Well, I wouldn't want to adjust that dose because they didn't get the insulin, so I don't know if that dose is right or not. So that's one way. The other way that we adjust insulin is by looking at patterns. So sometimes the fasting glucose is okay, and that determines your basal insulin, how it's working. And so if somebody's just high at mealtime, sometimes we'll just adjust the meal insulin and leave the basal insulin alone. There's a lot more people taking GLP-1s at home, like Ozempic and Mounjaro, some of the weight loss ones, Wegovy. What are some other ones you guys can think of? There's a whole bunch of them. They usually end with my brain is just not working, but they all end in, is it Tide? Yeah, TIDE. And so you'll want to ask the patient when you do the admission when the last time they took their medicine, the GLP-1s, because it's going to be in their system for 7 days if it's a weekly injection. And if they just took it, they're going to need less insulin than if especially if that's the only medicine they're on. And then if it's time, like if they say I took it on Saturday and you admit the patient on Friday, then you'll know over the weekend their blood sugar is going to start going up because their GLP-1 is going to wear off. The SGLT2 inhibitors are the gliflozins, like empagliflozin, and be on the lookout for euglycemic DKA, especially if they've had trauma or they've had surgery. If they're having scheduled surgery, they hold it for a few days before surgery. Also, the GLP-1s cause gastric emptying to be slowed. And if they are in a trauma and they have to have surgery, they're at risk to aspirate and have pneumonia because they usually hold those medicines for scheduled surgeries for a week so that the gastric emptying is back to normal before they put them to sleep. But if there's an emergency, they're going to put them to sleep, so you have to watch for that. So with the SGLT2 inhibitors, I have seen DKA with a patient with their blood sugar in the 200s. We had a patient that was transferred from an outside hospital to the neuro service, and they had done all kinds of tests on the person. And she'd had a CT, she'd had a lumbar puncture, she'd had an MRI, and she was transferred here because they couldn't find out why she had altered mental status. And when the neuro people did the H&P, they just documented that she was on 2 oral medicines, but they didn't pay attention to what kind of medicine she was on because they were already in that tunnel of my patient has a neurological problem. And so we got a consult because the blood sugar went over 200, and I went to see her, and one of the oral medicines she was taking was an SGLT2 inhibitor, and she had euglycemic DKA, and it had not been recognized at the outside hospital. And so we treated her with insulin, and within 24 hours, her mentation was back to normal, and she went home. She was discharged. So you have to look for it. You have to know to look for it, or it can be missed, and you can go down a pathway to the wrong thing. So one of the rare other thing that can happen with the SGLT2 inhibitors is Fournier's gangrene. Have you guys ever seen patients with Fournier's gangrene?
Yeah, but not from SGLTs.
Okay. Somebody's saying they have seen it, but it wasn't from an SGLT2 inhibitor. So we had a young guy recently that was in the hospital a long time that had Fournier gangrene, but I don't know if it was caused from this SGLT2 inhibitor, but he had been on an SGLT2. So of course we stopped it and we put it as an allergy. So if you have somebody with Fournier, whether it is from that medicine or not, they should not take an SGLT2 inhibitor going forward. It needs to be listed as a medication allergy. There are a lot of patients who are now taking empagliflozin in the hospital for heart failure. It is indicated in people that do not have diabetes for heart failure, because it helps you to your kidneys to pass the excess sugar in your blood, and it helps to keep your volume a little bit better. And so you'll see some patients in the hospital on empagliflozin. If you're going to start empagliflozin or any other SGLT2 or GLP-1, and the patient does have diabetes and they have good glycemic control, you're going to want to cut their insulin dose by 20 or 25%. So sometimes we'll have a person with diabetes to come in, and the heart team will start empagliflozin, and they won't realize they need to adjust the insulin dose. And so we'll usually take care of that. But we have had a patient or two that slipped through and ended up having some hypoglycemia. So just be aware of that. I already talked about glargine dosing with type 1 patients. One of the things we would love to do, patients with a pump, as you know, self-manage their diabetes. We would love to have a basal bolus power plan for self-management for some of our really savvy patients who like to manage their own diabetes. Because again, you don't have to wait for the nurse to come with your insulin if you have it. There are a lot of implications in the hospital because you're not supposed to leave insulin at the bedside because it's such a high-risk medication. And I know you guys see it, and I've seen it everywhere, where the pens are left at the bedside all the time, but they're really not supposed to. And then the other thing that's coming down the pike is that I'm going to be doing a talk at the Pharmacology CEU on May the 9th at the School of Nursing. And I don't know if you guys need pharmacology CEUs, but we're going to talk about diabetes meds that are used in non-diabetic patients, like your SGLT2s, GLP-1s, and some of the things they're used for. So that's a lot of stuff. Who has questions for me?
Do you not get euglycemic DKA with the GLP-1s?
You can get euglycemic DKA with the GLP-1s, but the SGLT2 inhibitors are more known for that. And that's why we don't use them in people with type 1 diabetes. When I think of GLP-1s, your most common side effect is going to be reflux because of the gastric slowing, constipation, nausea is the biggest one with your GLP-1s, and then huge amounts of weight loss. The weight loss with the GLP-1s, and especially the ones that are paired now, they have a dual medicine. Mounjaro has 2 meds in it, a GIP and a GLP, and patients are losing as much weight as if they had gastric bypass surgery. And actually, I've spoken with the weight management group because I'm their manager, and their patient population has drastically changed because of the GLP and GIP-1 meds and the success they've had with weight loss with those. So they're not seeing near as many bariatric surgery patients as they once were. All right, are you seeing any questions in the chat?
I have a question.
Okay.
So 2 questions. One is, are there any early signs for euglycemic DKA? And 2, because I hate to see it progress to altered mental status before we catch on to it.
Right.
And 2, I have run across several patients over the years that when they are well managed at home on their current regimen, they come into the hospital and they don't really want to alter it,
Right.
but based on the way that we would order it, it would be different than their home regimen. Is there a way that we should document that, or should we like really push harder for that to not be the case? Because I've had some that had really weird dosing,
Right,
um, but they have found that that works for them at home.
right,
I know I've had the conversation. Well, you may not be doing things at home the way you'd be doing them in the hospital. You may be on some different medications. Your body may be reacting differently based on whatever your diagnosis is and such. But in general, because I was called to the bedside not too long ago for a patient that he was upset because his blood sugars had been running over 200, and he's like, that never happens to me at home.
right.
So what are your thoughts on that?
Okay. So the first question was about euglycemic DKA, and the symptoms are often the same as DKA. So the person will start to have nausea, belly pain, vomiting. And so we usually tell patients if they start to have abdominal pain or nausea and vomiting at home just to hold the medicine and to make an appointment to be seen. If they're in the hospital, I usually just ask when I see a patient that's on an SGLT2 if they've had any nausea or vomiting or abdominal pain, just to screen for any signs and symptoms of euglycemic DKA. And then the second question, it varies based on the patient. And you are right, because of all the changing variables in the hospital setting, things are different. I mean, the person may be having hyperglycemia because they have an infected foot, or because they're having stress or pain or trauma, changes in their sleep pattern, changes in their activity level, changes in their diet. And so for the most part, if you stick to a standardized regimen, you have less chance of error occurring because they're getting the standardized care. But in having said that, we always want to individualize care. So for many patients, if it's early in their hospital stay, I'll ask them to try the basal bolus regimen. If they're on a basal bolus regimen and they're getting way more insulin than they usually get at home, or if there's some other issues or surrounding that, then a lot of times I'll go ahead and put them on their home regimen as best I can and see if we can get better glycemic control with that. And I know that's not a definitive answer, but I would just say use your best judgment. In most cases, basal bolus will take care of it, but I have seen a few times where the patient's home regimen was much better. 70-30 insulin, if you get that regular portion of the insulin, it hangs around longer. It's not in and out like Aspart or Novolog or Humalog. And so if you have somebody that grazes a lot, they may do better with the regular insulin in the 70-30 insulin, or if they have delayed gastric emptying. So there are some situations where they would do better on their home regimen, but we do like to have as many people as we can because most of the time they're going to do okay on basal bolus. So I hope that answered your question.
It does. It did bring up another question regarding dosing. I know we typically do once a day dosing on our glargine, but we do see people come in who take it BID. Do you have any recommendations on the benefit or the harm and the risk in doing BID dosing?
No, if they take BID dosing at home, I usually leave them on BID dosing.
Okay. Thank you so much.
That makes them feel better about us taking their insulin and doing things with it that's out of their
Gotcha.
Okay.
I have a question too.
Okay.
I work nights, and a lot of times, we'll get patients that just come in on oral glycemic meds. But let's say if you had a patient that was just coming in, let's say on like metformin or something, obviously we don't continue that.
Right.
Most of us, I think what we do is we'll put them on a sliding scale with the basal bolus, but a lot of times we don't start the long acting with glargine. We'll just do a sliding scale. Is that the best thing to do for those?
Well, again, it's kind of individualized. So the question is about a person that's coming in and they're only on metformin at home. And so what I would do in that case is look at their A1C. If they're only on metformin at home, but their A1C is high, and you may not have that for a while, I realize, then you could go ahead and put them on a low basal bolus power plan. They're only on one medicine at home, they're insulin naive, so that's really two risk factors for hypoglycemia. And especially if they're on like only 500 one time a day. So you want to look at the dose. You want to look at their A1C if you have one. But if there's any question, it's always better to err on the side of caution. So if I didn't know the A1C and they were only on metformin and they were a regular sized person with no renal failure, then I would probably just put them on a moderate correction, at least until I get the A1C back. And then sometimes they'll tell on themselves and you'll know you need to add some insulin. But it's better to not add it in the beginning and add it the next day than it is to bottom them out. Because if you come in and bottom your patient out the very first time you meet them, they're not going to have much confidence in the care you provide. So, you know, I did say we don't like to use sliding scale, but we had a patient this week that had type 1 diabetes and was on an insulin pump and was admitted, and they took the pump off and gave them sliding scale insulin because they were suicidal. They were suicidal risk, or they didn't want them to have their pump on, but they didn't give them any other insulin, and by morning they were in DKA. So you just have to make sure that they, you know the type of diabetes, the history of their control, and then just look at your other risk factors. Does that help?
Yes, it does. Now, speaking of the insulin pumps, you know, a lot of them I know have the, what's it called?
Continuous glucose monitor?
Yes, thank you. Where, of course, they don't want to be stuck.
Right.
So what do you do with cases like that?
All right, so we have been working on writing a policy for continuous glucose monitors in the hospital for a long time, but none of them are FDA approved to be used in the hospital setting. And so we always encourage the patient to have a finger stick blood sugar done, and then they can use their CGM to know what's going on for themselves. But if they absolutely refuse, then what we do is correlate the reading they're getting on their CGM with the labs and make sure it's similar. And you know, it's not going to be exactly the same. There could be up to a 20% difference. But then the biggest thing is documenting what the CGM says their blood sugar is. And there's a form in the ad hoc forms, and I think it's called self-monitoring or glucose self-monitoring. And the nurse can go in when she's, you know, doing vital signs. They can have the patient show them the CGM to see what the readings are, and you document it in the chart. Dexcom has been working for a couple of years to try to get FDA approval. And a lot of patients are already using Dexcom in the hospital, especially for certain patient types like people with type 1 diabetes. And you guys, if you think about it, how long have we had cardiac monitoring? Forever. I've been a nurse for 40 years, and we've had telemetry the whole time I've been a nurse. And so there's no reason why we shouldn't have continuous glucose monitoring, especially for our labile patients or patients with type 1, but it's just not been FDA approved. And we even tried to kind of go through the back door and do a research project and put continuous monitors on some patients, and the hospital just will not approve it because it's not FDA approved. So, but people do use them. They use them all the time, and they do refuse to be stuck. And so in that case, it's more, you know, the most important thing is to know what their blood sugars are doing. And of course, you can't make somebody do anything. And so we do encourage them, though, to have finger sticks done, but they don't always do that.
Okay, I have one more question, I'm sorry.
Okay, that's all right. That's why I'm here.
I had no idea the ER had to throw the insulin pens away.
I know.
What do you recommend then with those patients? Because we'll have patients down there sometimes 2-3 days waiting kind of bed.
I know. So she's asking, I don't know if you guys can hear the questions or not, so I'm repeating them. So she was asking about insulin pens in the ED and not knowing that they were being thrown out. Are you seeing them at the bedside? I think a lot of times they might be leaving them at the bedside like they do, and which they're not supposed to do. But it's a huge waste, and the insulin pens are very expensive. And while I'm thinking about it, I need to plug this. For all God's children in the whole world, never share an insulin pen between patients, because there was a hospital that had an outbreak of hepatitis C from nurses sharing insulin pens between patients. So I always tell that to everybody. I know you guys aren't using the pens yourself, but tell everybody you know, don't ever share a pen between two patients. They are single patient use only. And some of our people have HIV and hepatitis C and B and all kinds of fun stuff. But it's something that I would love to get our diabetes scholars to work on that as a project. If you could get them to put a lockbox in each room in the ED, then they could lock it in the box and use it over and over again. But trying to do, it sounds easy, but when you try to do one of those one little things, it's a lot harder to try to get things like that, to happen, because I'm sure there's a million other people that just want one little thing to happen. So, anyway.
I have a question too.
Okay.
At night on Crosscover, one of our frequent pages is like so-and-so's blood sugar is 400 at that 8 o'clock bedtime blood sugar, and there's a lot to it. Sometimes they didn't get the correctional, or they didn't eat, or they this or that.
Yeah.
But a lot of times that's a question people ask a lot is, well, how much would you give, or how would you adjust it, or would you give this and recheck? So what are your thoughts on?
So if a person has a blood sugar that's pretty high, like in the 400s at bedtime, or it's at an 8 o'clock blood sugar and you're on Crosscover, I would find out when they ate last. Because if they ate at 7 o'clock and they got the blood sugar at 8 o'clock, I would just give the night correction scale and not worry too much about that. And then, you could have them to check it again later in the night. If they didn't eat and their blood sugars are extremely high, maybe they didn't get their insulin dose at dinner, I would do a daytime correction dose for that. And just give them a little bit more insulin, because the night correction is about half what the daytime correction is, and for safety purposes. And then we can always catch up. Now, if you have somebody that's very, very hard to control, one of the other tricks that I use is I'll put the patient on every 4-hour glucose checks through the night and give them a daytime correction every 4 hours to try to get that blood sugar down during the night while they're not eating. And if you're nervous about doing that, you could give them the night correction every 4 hours. And then in the morning, you can use the total daily dose of insulin to greatly adjust your insulin dosing to get keep the blood sugar down. All right, well, I think that's, we have another question.
I have a question from the chat. Marcy wants to know, what type of needle do we use inpatient to refill the insulin pump when the patient doesn't have their supplies?
Okay. If the patient does not have their own supplies, they cannot refill insulin in their pump. They should not be sticking a needle through the other devices on their pump to fill it with insulin. The insulin pump cartridge that they use comes with a needle on it. And so if they have a new set, it has a needle that they can draw from the vial of insulin in, and then they screw off the plunger and they screw off the needle, and that cartridge then clicks into their pump. So if they don't have a new cartridge that has a needle, they need to come off the pump and go to basal bolus. And we can always help with that if you need us to. We're not here at night, but we try, if somebody's on a pump, to leave some recommendations for basal bolus if they need it. So you could look in our note and see if we've given, the directions on how to convert them to basal bolus if they need to. All right. Well, thank you guys so much.
Thank you.
That was a lot of stuff in a short amount of time. I hope it was helpful.
Information.